Мгм. Всё, можно начать уже трансляцию. Мгм. Good afternoon, students. We are about to start a lecture devoted to gynecology topics, pathological vaginal discharges, and pelvic inflammatory disease. Please sign in who is here, who is listening to us, and I'm gonna start the lecture. Pathological vaginal discharge is one of the main complaints, or sometimes can be a symptom of the different pathological conditions in women who come to the gynecological clinics or sometimes admitted to the gynecological department, obstetrical departments. So every doctor must be familiar with such symptoms and how to manage such problems. Normal vaginal discharge is characteristics of general health of women. Discharge flows from the vagina daily as the body weight, maintaining normal, healthy environment. Normal vaginal discharge usually clear or a little bit milky with no obvious bad odor. In women postmenarche or premenopausal women, vaginal pH is around 4.0 plus minus 0.2, and growth of pathogenic organism is usually inhibited. Normal flora, as it's shown on the slide, are lactobacilli. They're dominant in vagina. Also aerobic gram-positive cocci and anaerobic bacteria can be cultured. So microbiota in the vagina dominantly are lactobacilli, gram-positive cocci, and some anaerobic species. We need to remember that vaginal mucosa is a squamous epithelium, so layer is multi-layered, squamous epithelium, and no glands are inside the vagina. Which conditions may be connected to such symptom as pathological vaginal discharge? Mainly they are inflammatory conditions, such as vulvitis, vaginitis, or combined vulvovaginitis. Also cervicitis, inflammatory disease of the cervix, is maybe the cause of the pathological vaginal discharge. Or pelvic inflammatory disease, when inflammation of the uterus, appendages, sometimes urinary bladder is inflamed, and this may cause some pathological vaginal discharge. Although we have some specific disease, we call it bacterial vaginosis. It's not really inflammatory disease, but it still maybe may have some characteristics like discharge, pathological discharge, and patients need to be ruled out for other diseases. Not very frequently now, but sometimes it happens that fistula formation in the genital tract, usually after delivery, traumatic deliveries, or maybe some major surgery, gynecological or oncology surgery, and fistula formation may cause some pathological discharge. And foreign body in the vagina sometimes can be found by the attending physician, especially in the pediatrics. Small girls, they sometimes insert caps of pencils inside the vagina, or clips, paper clips, and can be found, and these foreign bodies can produce pathological discharge. Sorry. Let's talk about vaginitis. We sometimes call it colpitis because kolpos in Greek, in ancient Greek, and in Latin, vagina means vagina means vagina in English. The most common gynecological condition that patients come into the gynae offices. Usually, the diagnosis is based on the presence of different symptoms, and such of one of it is abnormal discharge, vulvovaginal discomfort, or combination of both. Especially, it's important to notice that change in amount, color, smell, irritation, and itching or even burning sensation could be due to imbalance of healthy bacteria in vagina, leading to vaginitis. Vaginitis is common in adult women and uncommon in prepubertal girls because the vagina is closed by hymen. Only when girls insert something into vagina, foreign bodies that I mentioned before. The most common causes of vaginitis nowadays are candidiasis, thrush, moniliasis, that's the same synonyms, vaginal candidiasis, up to 25%, as you see on the slide. Also, trichomoniasis or trichomoniasis, inflammation of the vagina caused by Trichomonas vaginalis, is also connected with pathological conditions, pathological discharge. Up to 75% of women with vaginitis may be undiagnosed for such condition because they may be just carriers, not obvious patients. As you see on the slide, a number of factors can change the composition of the vaginal flora, including sexual activity, hormonal imbalances, especially those who take hormonal contraception, poor hygiene, maybe poor water conditions. Immunology also play sometimes role for recurrent vaginitis and underlying skin disease. Actually, other factors like vaginal medications, over-the-counter medications, antibiotics, which we sometimes see the patients liberally use, and sexual transmitted diseases can be the cause of pathological discharge from the vagina. And don't forget about stress. Sometimes, because of the stress, patients start to feel bad in this topic in the vagina. What really happens is normally the pathological bacteria start to outgrow normal bacteria, which I mentioned before, like lactobacilli and gram-positive cocci. And those, for example, anaerobic microbes start to grow and cause inflammatory situation. Chemical irritation also be a significant factor. For women after the menopause, postmenopausal women, atrophic vaginitis is associated with hypoestrogenism and low level of estrogens already secreted. And such patients also, although they don't have obvious pathological microorganism, but still they have atrophic epithelium because of decreased level of estrogens in their blood. Let's talk about vaginal candidiasis or moniliasis or thrush. Sorry. As we see on the slide, Candida species, including Candida albicans tropicalis and glabrata, airborne fungi that are natural inhabitants of the vagina, up to 50% of women. But in 85-90% of cases, it is caused by Candida albicans, and only 5-10% of vaginitis, candidal vaginitis, is caused other species of Candida. Risk factors, as I mentioned before, include hormonal disbalance or orally intake contraceptives, like combined oral contraceptives. IUD users is an increased risk for vaginal candidiasis. It's noted by several studies. Young age at the first intercourse, this increased frequency of intercourse can be the cause of vaginal candidiasis. And other medical conditions like HIV patients and diabetes patients, many immunocompromised patients who use long-term use of antibiotics, and also pregnant patients, they suffer from pathological vaginal secretions and connected with candida infection. Trichomoniasis or trichomoniasis, it's actually transmitted disease because it's only can be transmitted via sexual intercourse, save for Candida vaginitis. It's not considered sexually transmitted. Um, uh, Trichomoniasis is sexually transmitted from male partner to female and vice versa, and it causes trichomonas cause vaginitis, inflammation of the vaginal epithelium. What is the trichomonas? Trichomonas is the oval-shaped, fusiform-shaped flagellated protozoa infection, very small, just the size of leukocyte, of white blood cell. These organisms primarily infect vaginal epithelium. Less commonly, they infect the cervix, urethra, Bartholin glands, skin glands. Trichomonas can be identified in as many as 80% of the male partners of infected women. Who is in increased risk for trichomoniasis infection? Usually, those ladies who have multiple sexual partners. Also, those who have unprotected intercourse, don't use barrier methods of contraception, and those who use an IUD. Also, it was noted that prevalence of trichomoniasis and trichomonas vaginitis are more common in tobacco users, tobacco smokers, and drug smokers. Some vaginitis may be not infectious and because of irritation due to chemical reaction or allergic reaction, and other cause of vaginitis, as I mentioned before, was atrophic vaginitis, which is commonly seen in postmenopausal women or women who takes antigonadotropic preparations, drugs, for the treatment of different gynecopathology, like, for example, we prescribe gonadotropin releasing hormone analogs for treatment of endometriosis or leiomyoma, and during the therapy course, level of estrogens diminishes to the low level, and atrophic vaginitis can be a symptom of such treatment. So what to do when the patient come to your office or to the hospital where you work and she complains of pathological discharge? You need to take good history. We say that the good history is the half of the diagnosis, a half of the good treatment. So you need to ask about previous similar episodes, ask about previous sexually transmitted diseases, infections. Of course, you need to understand the sexuality of specific patient and birth control methods, what she uses for contraceptive purposes. Of course, you need to ask about last menstrual period, because we don't want to lose pregnancy situations in patients who complain of vaginitis. Some patient may have two disorders at once, so don't forget about last menstrual period inquiry. You need to ask about douching practice. As I mentioned before, uh, poor hygiene is a risk factor for vaginitis formation, although and excessive douching is also not very good for patients because they move away the protective layer of epithelium, vaginal epithelium. It's not very good, and those patients are more susceptible to vaginitis problem. Uh, Antibiotics use, ask the patients, and you need to remember and to know general medical history of such patient. Maybe she's takes systemic corticosteroid drugs, medicines for treatment, for example, systemic disorders like um, arthritis, maybe for other reasons. So this is very important to remember, and ask about other systemic symptoms like low abdominal pain, chills, nausea, fever, and probably sometimes vaginal discharge is the symptom of major disease like pelvic inflammatory disease, and we will talk about in the second part of my presentation. But sometimes vaginal discharge is the symptom of low inflammatory situation like vaginitis. So ask about other systemic symptoms: fever, nausea, vomiting, and abdominal pain. Couple of slides which demonstrates you the cervix, vaginal wall. We must remember that during the speculum examination we see not only vaginal walls, we see also the cervix, which is the upper part of the vagina, close the vagina from high point. Uterus with its cervix is located in the very apex of the vagina. So you see on the slide, probably you see, I'm trying to show on the left, this is cervix, and the vagina is full of white gas formating discharge, and it's red. So it's not pink red, it's red. And to the right, in the middle, you see the cervix is not covered by squamous epithelium. You see the erosion of the cervix and white cotton cheese-like discharge. And to the right, to the left, you see again another cervix. It's not inflamed. It's a little bit cyanotic, and it covered, and walls of the vagina are covered by white gray smooth discharge. So you need to assess the vaginal walls, cervix during the speculum examination. It's not difficult. It's easy. All you need to be attentive, patient, and ask patients about her sensation. Okay, you need to see the quantity, amount of vaginal discharge. Ask about when did it start. You must notice the color, the consistency, and also it's better to check the order because some pathological discharge may have specific order, and we'll continue. Look at this slide and the picture you see on the arrows. The arrow is inside it shows us that it's the cervix is covered by white cotton cheese-like discharge, and the cervix and vaginal walls are inflamed. So it's hyperemia, you see. So erythema is seen. Vulva and vagina, usually a little bit edematose, possibly sometimes it's excoriations may be seen or fissures seen, and thick cotton cheese-like vaginal discharge may be seen, like on this slide. And by the way, cervix itself appears normal, conic form, it's okay. So this is very typical picture of vaginal candidosis or candida vaginitis. It's almost the same. Candida vaginitis means that this patient has inflammation of the vagina. And usually we say vaginal candidiasis when just no inflammation but carriers of the candida infection and no obvious disease. But that's for candidiasis. If it's, now I'm showing you another slide, and on the pictures you can see, on the photographs you can see the cervix and the vaginal wall, which are inflamed, and you see a strawberry-like pattern on the cervix, like dots, many red dots. Uh, this is a specific symptom when you do speculum examination for trichomoniasis vaginitis. So we sometimes Mother Nature gives us advices what is it, what to do. So be attentive, doctors, and you must remember some specific symptoms. Yeah, and small punctation, cervical punctation, vaginal hemorrhages, which with ulcerations may be observed. If we speak about other causes of vaginitis, pathological findings associated with atrophy, dysplasia, vulvar vestibulitis, vaginal foreign bodies in adults include forgotten tampons, findings of full odor and irritation with purulent discharge, common in such situations. Sometimes patients may forget their tampon, and they think they took it away, but really they come to their office and start to complain for malodor discharge, and during speculum examination you can easily find it. Of course, it's very maybe dangerous situation, forgotten foreign bodies, especially tampons, because they may cause septic shock syndrome, because those exotoxins, they are absorbed by vaginal epithelium, so you need to pay attention to such patients, to prescribe antibiotics, and sometimes you need to put IV support, intravenous normal saline or ringer lactate support. Patients with pinworms may present with few physical findings. Occasionally, these patients may have erythema, excoriations around anal area. In severe cases, eggs or dead female nematodes may be seen on examination of the anal canal. Perianal streptococcal dermatitis usually result in beefy red peritoneal area that is edematous and tender. Fissures, drainage, and hemorrhagic spotting may be present. In about 50% of all cases of mucopurulent discharge in women, the etiology is still unknown for us. Up to 50% of mucopurulent discharge. That's the bad story. So we need to pay attention to lab diagnostics in such patients. What is the differential diagnosis of patients who come with vaginal discharge with some inflammation conditions inside the vagina? Don't forget about lichen. Lichen simplex chronicus can be one of the possible situations, especially in postmenopausal women, elderly postmenopausal women. Vaginal adenosis, changes of epithelium in the vagina. Vaginal cancer, also, although it's quite rare, also we need to keep in mind that some patients, especially elderly women postmenopause, they may have some neoplastic processes in the vaginal epithelium. Vaginal ulcers as a result of sexual intercourse, aggressive sexual intercourse may be seen, and vaginitis emphysematosa, when multiple gas-filled cyst on the vaginal cervical epithelium is seen. It's quite rare, by the way. All women should have a careful pelvic examination, and of course, we need to take smears and tests for infections. Of course, sometimes we use colposcopy and even use cervical biopsies or vaginal biopsies in order to rule out suspected cancer, cervical or vaginal. What test is necessary to do? Very popular in Western countries, United States, Canada, in Britain, wet mount preparation, so-called WIF test, pH testing. Every office of the gynecologist should have pH tests for knowing what the pH is inside vagina. As I mentioned before, normal pH is slightly acidic, around 4.0 plus minus 2. If we speak about lab diagnostics, so gram staining smears is necessary to take to rule out necessary gonorrhea. Culturing is very useful tool for testing patients, and now everybody knows about PCR, nucleic acid amplification testing for coronavirus. Also, the same ideas, not for coronavirus but for other species, may be taken PCR tests. A saline wet mount is very easy to do in the office if you see not very powerful. If you have not even if you have not very powerful microscope, you can put a drop of vaginal discharge on a slide, put a couple of drops of normal saline, and examine under their high power. In patients with vaginal candidiasis or candida vaginalis, the test reveals hyphae, budding of yeasts, so it's quite obvious. In symptomatic women with trichomoniasis, usually when you do saline wet mount, you see increased number of leukocytes in the power field, and sometimes you see movements of trichomonas. But of course, it's necessary to have some expertise to understand what you see. The WIF test, it's very easy to do. All you need for this is to have in the office 10% potassium solution, kali hydroxide solution, and you put a couple of drops of this solution on a vaginal discharge, and when the fishy odor, specific amine odor appears, it's very suggestive for bacterial vaginosis, so-called dysbiosis in the vagina. The odor is due to release of pitocin, cadaverine, histamine, and they're very obvious. A negative test result usually seen in Candida vaginalis, because there is no such amines like in bacterial vaginosis, which is caused by anaerobic infection, anaerobic growth, like Gardnerella vaginalis microbe, or Peptostreptococci as well. WIF test may be positive in Trichomonas infection, so don't forget about this. Vagina pH acidity, as I mentioned before, must be around 4. When it is greater than 4.5, it's suggested for Trichomonas vaginitis or bacterial vaginosis. And you see on the slide that bacterial vaginosis, usually pH goes more than 5.0.
And for vaginal vaginitis, acidity is maybe low because vaginitis ions of hydrogen is increased. Uh, pH in vaginal candidosis usually below 4.5. But trichomonas infection, trichomonas infection usually rises high. Um, what we send to the lab, or in some countries, doctors do it directly in the office. They the gram staining uh, is very sensitive for detecting bacterial vaginosis and rule out intracellular gram-negative Diplococcus. Uh, so for the technique is described in microbiology textbooks, and you can read it there. Uh, gram stain and culture in Nickerson, Medio, and Sapporo. Agar may enhance diagnosis in vaginal candidosis. Pap smear may have frequent false positive results in case of yeast infection. So don't forget about this. It's not necessary to do directly pap test if patient comes to you and her discharge is very suggestive um, for yeast infection. Uh, uh, Nucleic acid amplification test, or PCR tests can be performed by using swabs, taking swabs from cervix or vagina, or sometimes collecting urine samples. It very sensitive and specific for detecting several microorganisms like Trichomonas, like Candida, like Neisseria gonorrhoeae infections, chlamydia infection as well. So nowadays we use a lot of those tests for proving our diagnosis and when prescribing specific treatment for such patients. Cultures of the vaginal secretions, it's very important to know because cultures may also tell you the accessibility to antibiotics, specific antibiotics. So it's very good if we take not only smears, uh, sorry, not only smears, but excuse me. Um, it's good not only for to take on the smears PCR test, but it's sometimes in refractory cases it's good idea to use cultures to culture secretions and to see what is the possible microorganism which is maybe the cause of inflammatory situation in the vagina. Uh, if you do chlamydia trachomatis test, PCR test, especially in prepubertal girls and patients who show signs of sexual abuse, and in such patients also it's better to take rectal chlamydia swabs and send results. If it is so, if it's positive, you need to do legal information to send legal information to the authorities. In quite rare histological findings in patients with vaginitis, quite rare we do it, but sometimes it's necessary to do. What can you see in histology? Cholestatic atypia caused by human papillomavirus and trichomonas infections can be confused with this. Also, may mimics mild dysplasia of the vaginal epithelia. So it's maybe important to know. Bacterial vaginosis may produce inflammation and atypical squamous cells of undetermined significance, so-called ASCAs. This is one of the grade of the PAP test. As we say, not necessary to take all tests, for example, to take pap test when patient comes to your office with complaints of vaginal discharge and possible inflammation of their vaginal walls and the cervix. It's better to postpone such test when you will heal the patient with vaginitis. Anyway, we are good doctors, so we need to treat good our patients. So what is our remedy for patients? Treatment varies. Treatment varies because different causes and different etiology of vaginitis. So anyway, the goal for any therapy is to alleviate symptoms, reduce morbidity, prevent complications, and decrease their chance for relapse, recurrent infection or vaginitis. So the goal is this. So which drugs can be used? We will speak right now. Usually we prescribe drugs for vaginitis which are applied topically and may require oral or parenteral administration. But usually we prefer to treat local problems locally. Atrophic vaginitis can be treated with lubricants, estrogen creams, vaginal creams, some tablets available which contain estrogens, rings, and other stuff. Vaginal suppositories, vaginal pills containing human lactobacilli strains are under investigation so far. So, but some pharmaceutical companies, they provide studies, they support studies, and these preliminary studies shows that may be of help in patients with, for example, with recurrent Candida vaginitis, when lactobacilli goes down, and it may be necessary to insert those suppositories for the prevention of relapse. You see on the slide how many, plenty of drugs, preparations, medicines are used for the treatment of the single vaginitis caused by Candida infection. Many of them. And I didn't mention the brand names. We may need to multiply to 10. But nonetheless, the definite treatment for Candida vaginitis is not yet solved. We have different agents, intervaginal agents like voriconazole creams or suppositoria, clotrimazole creams or suppositoria, and it works in some extent. We don't have a full remedy for Candida vaginitis. Maybe 20 years ago, when fluconazole, an oral agent, appeared on the pharmaceutical market, many doctors thought this is the final remedy for vaginal candidosis. Not that story. Of course it helps, of course it works well in many patients, but not 100% patients, and it doesn't prevent relapse, because many patients may have preliminary conditions, predominant conditions which may lead to vaginal candidosis. So anyway, you see on this slide many drugs like nystatin, probably you remember, and miconazole and clotrimazole, very popular nowadays. So you can take a photograph from this slide and read it later. Recommendations for complicated vaginitis, the Candida vaginitis, when 4 episodes of symptomatic vaginitis in a year, usually 7-10 days of topical therapy, of 10, 100 or 150 milligram oral dose of fluconazole every third day for a total of 3 doses, so day 1 for 7 for maintenance. Usually prescribed. Severe vulvar vaginitis candidosis, 7-14 days of topical fluconazole therapy, like fluconazole or clotrimazole therapy, or 150 milligrams of fluconazole repeated in 3 days. And plus, nystatin cream is very beneficial. When it is non-albicans candida vaginalis, you need to use other preparations, like, for example, boric acid in gelatin capsule, 600 milligrams, very useful for such patients, and insert it vaginally twice for 2 weeks. When patients is compromised, 14 days of topical therapy. In pregnant patients, many of the agents and many preparations are not recommended. Fluconazole is contraindicated. Usually, nystatin cream is okay for pregnant women, and also pimaflucin is very popular in our country for treatment of vaginal candidosis in pregnant patients. Trichomoniasis vaginitis is usually treated by metronidazole, which is usually taken orally 2 grams as a single dose, or you may divide by 500 milligrams twice daily for 7 days. Also, tinidazole 2 grams orally as a single dose works very well for trichomoniasis patients. You need to remember that both partners should be treated, not only female patients, only her sexual partner, because I mentioned before, this is the sexually transmitted disease. Usually, quite often, it's accompanied by other sexually transmitted diseases like chlamydia or Neisseria gonorrhoeae. So don't forget to check for those infections also. Pregnant women may be treated with metronidazole, although it's contraindicated in the first trimester because it may have harmful effects on fetuses. So you need to postpone treatment with metronidazole in pregnant women. Lactating women should postpone breastfeeding during treatment for 1 day after the last dose of metronidazole. Then they may continue their breastfeeding. For women taking tinidazole, breastfeeding should be interrupted during treatment for 3 days after the last dose. Topical treatment with nonoxynol 9 and povidone iodine shown to be effective in treating trichomoniasis in women unable to use metronidazole. So povidone iodine, betadine cream or suppositoria frequently recommended for pregnant women in the first trimester because they are not harmful for future baby. Prognosis for most of the vaginitis patients are very good. Many of them cured completely. Recurrent vaginal infections can lead, of course, to chronic irritation and scarring formation in vagina. So that's the bad story, but it doesn't happen very often. Of course, there's in such patients you can if you see some sexual dysfunction and emotional stress also can be seen. In pregnant women, Trichomonas vaginitis and Candida vaginitis are associated with an increased risk of adverse pregnancy outcome, including preterm labor, premature rupture of membranes, which is actually the same for bacterial vaginosis, which is not obvious inflammation of the vagina, but several studies showed us that bacterial vaginosis also connected with premature rupture of membranes and preterm deliveries. So, and this also leads to low birth weight infants and postpartum endometritis, which is not very good. A couple of words about bacterial vaginosis. It's a non-specific vaginitis itself. It's, as I mentioned before, it's not vaginitis. It's better to say it's vaginosis because it's not inflammation. But many studies demonstrated connection with Gardnerella vaginatis and other Bacterostreptococci, Fusobacteria, Mycoplasma, Ureaplasma also can be seen in cultures or PCR tests in such patients. Vaginal flora usually becomes altered through known and unknown mechanism, causing an increase of the local pH, which may result in reduction of hydrogen peroxide producing lactobacilli. So the normal vaginal microbiotics associations is crushed, and Gardnerella or other anaerobes start to grow and form biofilms in the vagina, and those patients become symptomatic with vaginal odor, vaginal discharge, and sometimes less common vulvar irritation, and dyspareunia, and sometimes dysuria also present. Risk factors for bacterial vaginosis are antibiotic use, decreased estrogen level in the blood, IUD users, douching, as I mentioned before, sexual activity, especially with increased number of sexual partners. You have seen on the photograph the typical bacterial vaginosis discharge, which is adheres to the vaginal wall, homogeneous, gray thin, a large amount of such discharge, not green, they usually white or white-gray. No inflammation of the vaginal wall, or vulva, or cervix. So usually this is non-inflammatory conditions. How to diagnose bacterial vaginosis? On microscopic examination, we must see 3 out of 4 criteria, which we call AMSL criteria, which is considered necessary to diagnose. Clue cells, which actually are epithelial cells covered by Cocci bacteria. Clue cells on the saline smear. pH is elevated, specific discharge, and positive whiff test. So-called Nugent's criteria may be used to quantify grade bacteria by gram staining of vaginal samples. These criteria evaluate the following types of bacteria and score to each. For example, the amount of lactobacilli, you can score between 0 and 4. Bacteroids like Gardnerella, the same situation. Mabelanchus, from 0 to 2, calculate. And if total score is elevated more than 7, number 7, more than 7, 8, 9, 10, it is bacterial vaginosis. If the score less than 3, the Nugent's criteria considered normal, which is between is an intermediate bacterial count. Culturing, usually we don't take in case of bacterial vaginosis because this is polymicrobial infection. However, obtaining to exclude other microbes like trichomonosis, Chlamydia trachomatis, or Neisseria gonorrhoeae is appropriate. Recent research indicates that the genital cytokine profiles may be used as a biomarker of sexually transmitted diseases and bacterial vaginosis to identify women with asymptomatic treatable infections. Quantitative PCR test is useful for evaluation for bacterial vaginosis response to treatment in pregnant women. So what is the treatment for bacterial vaginosis? Antibiotics remains the main therapy for bacterial vaginosis, usually local antibiotics active for Gardnerella and other species. And wash hygiene with using hypoallergenic bar soaps and no soap at all is recommended. We usually recommend to avoid liquid soaps and body washes. So what is the specific antibacterial treatment for bacterial vaginosis patients? First, the same like for trichomonas, it is metronidazole, usually taken orally or vaginally. Clindamycin, which usually is prescribed by vaginal suppositories, vaginal cream. Secnidazole, it's a single dose oral treatment for bacterial vaginosis. For non-pregnant women, metronidazole is okay. This almost the same schema like for the treatment for vaginal trichomoniasis. 500 milligrams of metronidazole twice a day for 7 days, or single dose 2 grams orally. In pregnant women, metronidazole is recommended only after the first trimester, so second and third trimester. Clindamycin, antibiotic, is recommended orally 300 milligrams orally twice a day for 7 days, or vaginal cream for 5 days, or vaginal capsules daily only for 3 nights. Very convenient schema. And now we'll take a 5 minute break, and I'll continue in 5 minutes. Thank you for your attention. I'll be back in 5 minutes.
Okay. Uh, we'll continue. I hope you're here. If you have some questions, you can. I hope you can send it here. I'm not sure will I see it, but in case, I hope you'll understand everything. So, pelvic inflammatory disease is an infectious and inflammatory disorder of the upper female genital tract. Contrary to vaginitis, which is lower part of internal genital organs. Pelvic inflammatory disease is usually related to upper female genital tract and includes uterus inflammation and fallopian tubes inflammation, ovaries inflammation, and adjacent pelvic structures. When it is inflammation of tubes and ovaries, we tell it salpingo-ophtheritis or adnexitis. Pelvic peritonitis is inflammation of pelvic peritoneum, which covers internal pelvic organs in the female. WHO determined that sexual transmitted infections rank in the top 5 disease categories for which adults seek care. Women in resourceful countries, especially those in Africa or Asia, experience an increased risk of complications and different sequelae. Annual rate of PID in high-income countries has been reported to be as high as 10–20% per 1,000 women of reproductive age. PID affects more than 800,000 women in the United States yearly, and prevalence in Latin America and Caribbean region is 37 per 100 women. So quite high prevalence of pelvic inflammatory disease now. How does it start? It's initiated by infection that is sent from the vagina and cervix. Usually chlamydia trachomatis play the role in starting PID. Acute episode of PID is connected is less than percent positive for sexual transmitted organisms. So not in all cases we can find specific microorganism like chlamydia or Neisseria gonorrhoeae. Probably this is because patients may start treatment before going to the doctor's office or before admitted to the hospital. Other organisms also play a role in pathogenesis of pelvic inflammatory disease, and such microorganisms we already discussed. They may be in Gardnerella vaginalis and Haemophilus and other anaerobes and bacteroids. Laparoscopic studies, laparoscopic surgery have shown that up to 40% of cases PID is polymicrobial association. Most cases of PID are presumed to occur in two stages. The first stage is acquisition of getting vaginal or cervical infection. This infection is often STD and may be asymptomatic. So patient doesn't see much uh, symptoms in that time. But the second stage is a direct going up of the organisms from vagina to the cervix to upper part of the genital organs, and the real inflammation starts. The mechanism by which microorganisms go up from lower genital tract isn't clear. Studies suggest that multiple factors may be involved, for example, cervical mucus, diminished barrier, uh, the efficacy of this barrier may be decreased by vaginal inflammation or by hormonal changes, and which is maybe occurred during ovulation. Probably this is one of the mechanisms. Bacterium also carried along with sperms, and even on the sperms mounted on the sperm, they may get into the uterine cavity and fallopian tubes and peritoneal cavity. So ascent of the infection by lymphatic spreading or hematogenic spreading also may be seen in such patient. Inflammation of the fallopian tubes initially affects the mucosa of the tube, but inflammation may rapidly become transmural, and this inflammation appears to be mediated by complement, may increase in intensity with subsequent infections. Inflammation may extend to uninfected parametrial structures, including bowel. Infection may extend by spillage of the mucopurulent discharge material from fallopian tubes or via lymphatic spread, even beyond the pelvis, and may produce acute peritonitis or acute perihepatitis, so-called Fitzhugh-Curtis syndrome. It's shown on the photograph below, such strings in a perihepatic space. Below you can see liver surface, and this is the perihepatic space, and many strings formed after patients suffered from perihepatitis. And on the upper photograph, you see inflamed, dilated, filled with mucopurulent discharge fallopian tubes. Fallopian tube, sorry. It's a right fallopian tube. PID rarely occurs in pregnancy, very rare, because pregnancy probably plays a protective role, protective mechanism. However, chorioamnionitis can occur within the first 12 weeks of gestation, so we need to remember it. And when we say about family planning, we need to emphasize that necessary to give some lab tests for ruling out bacterial contamination in vagina and cervix. Concurrent pregnancy influences the choice of antibiotic therapy and demands that alternative diagnosis of ectopic pregnancy must be excluded. Uterine infection is usually limited to the endometrium, but may be more invasive and in a gravid or a postpartum patient. Genetically mediated variations in immune response play an important role in susceptibility to PID. Variants in the genes that regulate toll-like receptors, an important component of the innate immune system, have been associated with increased progression of chlamydia trachomatis infection to PID, from the carriers to obvious pelvic inflammatory disease. Possible contributing role of 5 single nucleotide polymorphism in 4 genes encoding pattern recognition receptors in local tubal cells and circulating immune cells like macrophages. So genetic plays a role in
acquiring episode of obvious acute pelvic inflammatory disease. On the slide, you see plenty of microorganisms which may help Neisseria gonorrhoeae and chlamydia organisms to light the fire of pelvic inflammatory disease. Many of them are anaerobic or sometimes viruses like herpes virus also can be seen. It's interesting that so far we don't have much studies regarding coronavirus as a possible cause of pelvic inflammatory disease, but I saw in the literature that vaginitis can be caused by coronavirus, which can be transmitted during their oral vaginal sex. HIV infection is associated with increased incidence of infection and pelvic inflammatory disease. So those patients are immunocompromised, and we need to remember this. Neisseria gonorrhoeae can facilitate HIV transmission via modulation of HIV-specific immune response. Women with HIV also have increased risk of progression to PID from simple vaginitis and even to tubal ovarian abscess formation because of weak immune response. One study found an association between PID and bacterial vaginosis bacteria. 4 new species detected were Smithia leptotrix, Smithia amnioni, and Atapobium vagina, which is also associated with bacterial vaginosis. Risk factors was the same, like for vaginitis, it's multiple sexual partners, history of prior sexually transmitted infections, and history of previous pelvic inflammatory diseases, sexual abuse, excessive douching has been considered risk factors. Gynecological surgical procedures which affect the cervix, such as cervical biopsy, endometrial biopsy, dilatation and curettage for pregnancy termination or for diagnostics reasons, cancer diagnostics. Hysteroscopy, they may break cervical barrier and predispose ascending infection, inflammation to the upper genital organs. Younger age has been found to be associated with increased risk. Increased cervical mucosa permeability, when you can see in case of cervical erosion or cervical ectopy, and elderly women are more likely to be affected with non-sexual transmitted organisms. The symptoms of pelvic inflammatory disease should be quite obvious for any doctor. First, patients with PID present with toxic symptoms: fever, temperature more than 38 Celsius, nausea, vomiting, pelvic pain, quite obvious. Although sometimes patients may be quite asymptomatic, minimally symptomatic. When PID is caused by gonocoque or Neisseria gonorrhoeae, it's thought to have an abrupt onset with more toxic symptoms than non-gonococcal cause of pelvic inflammatory disease. Gonorrhea and chlamydia-associated infections are more likely to cause symptoms toward the end of the menstruation and in the first 10 days following menstruation. A lower abdominal pain is usually present. The pain is typically described as dull, aching, or crampy, bilateral, usually bilateral, because pelvic inflammatory process takes the whole internal organs, not right side or left side. And it is maybe very useful when you think about appendicitis in women. Or it usually begins a few days after the onset of the last menstrual period and tends to be accentuated by motion, exercise, or sexual intercourse. Pain from PID usually lasts less than 7 days. Uh, if the pain lasts longer than 3 weeks, the likelihood that the PID is correct diagnosis declines. Abnormal vaginal discharge usually present in patients with pelvic inflammatory disease. Sometimes vaginal bleeding can be seen, often postcoital. Temperature higher than 38 Celsius is found in more than 30% of cases. Nausea and vomiting manifest late in the clinical course of the disease because of toxemia. Abnormal uterine bleeding is present in more than 1/3 of the patients. So let's repeat: fever, toxic symptoms like nausea, vomiting comes later, abnormal vaginal discharge usually present, and dyspareunia also can be seen, and abnormal vaginal bleeding is seen in such patients. Physical examination usually reveals tenderness of the lower abdomen. By manual examination, you can check the cervical motion tenderness, uterine and nexal tenderness, rebound lower abdominal tenderness, and involuntary guarding may be noted, and it is suggested for pelvioperitonitis. Right upper quadrant tenderness or pain, especially which is associated with jaundice, yellow changes of the skin, may indicate for Fitzhugh-Curtis syndrome, which I showed you on the photograph, perihepatitis syndrome, which is not very uncommon. The differential diagnosis for pelvic inflammatory disease, acute appendicitis, cervicitis, urinary tract infections, endometriosis, ovarian cyst torsion, interstitial cystitis, and less commonly adnexal tumors. A delayed diagnosis or treatment can result in long-term sequelae such as chronic pelvic pain, chronic PID, and tubal form of infertility. All female patients of reproductive age with lower abdominal pain require pregnancy test, because we don't want to forget that sometimes PID may happen among pregnant women, and if we treat with antibiotics, we don't want to harm future baby. PID is the most common incorrect diagnosis in cases for ectopic pregnancy. So sometimes doctors, they miss ectopic pregnancy and they think it is just pelvic inflammatory disease. So we don't need to forget to do pregnancy test, HCG test, urine HCG test, and blood HCG test for ruling out pregnancy, both uterine and ectopic. Laparoscopy usually is not done for pelvic inflammatory disease diagnosis, but sometimes it's necessary to do, and it's considered as a gold standard for definite diagnosis of pelvic inflammatory disease. But nonetheless, we don't use routinely laparoscopy nowadays for the diagnosis of pelvic inflammation. Additional criteria can be oral temperature higher than 38.3 Celsius, abnormal cervical and vaginal mucopurulent discharge, pus, abundant leukocytes in a staining, in a smears, elevated erythrocyte sedimentation rate in the CBC, complete blood testing, elevated C-reactive protein, more than 60 milligram per liter, and lab tests evidence for Neisseria gonorrhoeae, gonococci, or Chlamydia trachomatis can be useful. What about ultrasonography? It may be helpful for as additional method of diagnostic in disputable cases. Scanning is easily to do transvaginally or transabdominally. And this modality is non-invasive and usually recommended for patients with suggestive for pelvic inflammatory disease. There are a couple of photographs. Formation of the tubo-ovarian complex is seen on those slides. CT scans, MRI usually is not utilized for the diagnosis of pelvic inflammatory disease. But also, although it has relatively high specificity and sensitivity, up to 95%, but it's very costly and rarely utilized. Hydrosalpinges are easily now visualized on ultrasonic devices, so it's necessary to do MRI or CT scan to see pyosalpinges or hydrosalpinges or tubo-ovarian abscess formations, which of course are much easier to see on MRI, but more than the ultrasound machines, they very specific and very useful to diagnose pelvic inflammatory disease complicated by abscess formations or hydrosalpinges formation. Cholecystectomy is one of the medical gynecological procedures which is done under local anesthesia or maybe light intravenous sedation. It's easy to perform in an ER, emergency room, if you suspect inflammation of the Douglas pouch of Douglas, or as well you can exclude hemorrhagic fluid inside the pouch of Douglas, so it's very easy to perform even to unexperienced gynecologists or unexperienced doctors. Treatment of the pelvic inflammatory disease should alleviate symptoms and eradicate current infection and minimize long-term sequelae. So the earlier diagnosis, the earlier the treatment, the better the outcome for future both reproductive life, fertility life, and for sexual life as well. Hospitalized or not hospitalized patients depends on the status of the patient. Most patients with PID now can be managed as outpatient patients, but hospitalization should be considered for patients with uncertain diagnosis, with if you suspect pelvic abscess and if you suspect pregnancy, both intrauterine or ectopic, when the patient cannot tolerate oral antibiotic regimen or not compliance with this patient is not very good. In case of severe form of illness, immunocompromised patients, for example, HIV patients with low CD4 count, is necessary to hospitalize. And if patient is not improved clinically within 74 hours of outpatient therapy, you should ask the patient to come back and send it to the hospital. The Center for Control of Disease in the United States lists currently 2 accepted treatment protocols for outpatient treatment. Regimen A consists of ceftriaxone intramuscularly plus doxycycline orally for 14 days, for 2 weeks, and metronidazole also 500 milligrams orally twice a day for 2 weeks, recommended in such patients. Regimen B, another cephalosporin, cefoxitin, 2 grams intramuscular, plus doxycycline, 100 milligrams twice daily orally, plus metronidazole, which covers anaerobic infection, again for 14 days. Sorry. If patient is admitted to the hospital, Center for Disease Control, 2 current regimen is recommended. The same cefoxitin 2 grams intravenously every 6 hours, so 4 times a day, or cefotetan. Again, you need to give doxycycline, 100 milligrams orally or intravenously twice a day, and this regimen is continued for 1 day after the patient clinically improved. If the patient is improved, doxycycline can be given orally twice a day for 14 more days. In case if tubular ovarian abscess is present, clindamycin is recommended, or metronidazole is recommended with doxycycline. The second regimen can be clindamycin, 900 milligrams 3 times daily intravenously, plus gentamicin intravenously as the loading dose, followed by a maintenance dose, as recommended on the slide. The patient should be followed up, and because we remember that recurrence rate is quite high, so every 6th person, every 5th person can have some recurrence for pelvic inflammatory disease. So it's necessary to counsel such patients. They need to use proper hygiene, sexual hygiene, prevent sexually transmitted diseases, infections by using barrier methods of contraception. Systemic oral contraceptives usually is not recommended in case of pelvic inflammatory disease. For contraception, it's better to use condom or both condoms and contraceptives. Prior to insertion of intrauterine device for contraception, vaginal sampling, vaginal tests should be done for excluding microbiology contamination. And we need to remember that patient who has already suffered with pelvic inflammatory disease, 5 to 10 times higher rate of ectopic pregnancy and both infertility. So such patients should be monitored. If patient with pelvic inflammatory disease gets pregnant, you need to rule out this pregnancy can be ectopic. So this patient should come to your office sooner than the rest of patients who didn't have pelvic inflammatory disease. This is all for now. I hope you obtained necessary information from me, and we'll discuss with some of you this information also on our practical seminars and workshops. Have a nice day. See you. Have a nice weekend.